Male hypogonadism, diagnosis and testosterone replacement therapy. Male hypogonadism effects is almost equal to 2.5% of men greater than or equal to 40 years and up to 5% of men greater than or equal to 60 years worldwide, imposing a measurable economic burden through reduced productivity and increased healthcare utilization. The condition results from impaired Leydig cell testosterone synthesis due to primary testicular failure or secondary hypothalamic pituitary dysfunction, leading to a cascade of androgen-dependent metabolic derangements. Diagnosis hinges on a reproducible total testosterone less than 300 ing/dl, 10.4 nmol/L, on at least 2 morning samples, coupled with clinical symptomatology and, when appropriate, gonadotropin profiling. First-line management is testosterone replacement therapy, TRT, most commonly administered as intramuscular testosterone enanthate 100 mg weekly or transdermal 5G gel daily, with treatment goals of achieving serum testosterone 3001000 ing/dl, alleviating symptoms, and minimizing adverse events. Key points. Note: primary, testicular, hypogonadism accounts for is almost equal to 30% of cases, while secondary, hypothalamic pituitary, hypogonadism accounts for is almost equal to 70%, NANS 2018. A total testosterone less than 300 ing/dl, 10.4 nmol/L, on 2 separate morning draws has a sensitivity of 92% and specificity of 88% for clinically significant hypogonadism. Endocrine Society 2018. Testosterone enanthate 100 mg intramuscularly weekly raises serum testosterone by an average of plus 350 ing/dl within 2 weeks. Mean plus or minus SD plus 350 plus or minus 120 ing/dl. Transdermal testosterone gel 5G daily delivers is almost equal to 50 mg testosterone and achieves target levels in 84% of patients by 8 weeks. T4 trial, 2016. Hematocrit greater than 54% occurs in 510% of TRT users. Routine monitoring reduces severe erythrocytosis, NNT equals 12. Prostate-specific antigen, PSA, elevation greater than 1.4 nanograms per milliliter after 12 months of TRT occurs in 3% of men, with a false positive rate of is almost equal to 2%. AACE 2020. Cardiovascular event risk, MI or stroke, within 2 years of TRT initiation is 1.3% versus 0.9% in matched controls, HR equals 1.44, 95% CI 1.1 to 1.84. Quality of life, QOL, scores improve by plus 12 points on the androgen deficiency in the aging male, ADAM, questionnaire, NNT equals 7. TRT discontinuation rates at 12 months is almost equal to 22% due to adverse effects or inadequate symptom relief, Real-World Registry 2021. In men greater than or equal to 65 years, a reduced starting dose of testosterone gel 2.5G daily achieves target levels in 71% while limiting hematocrit rise. Beers Criteria 2022. Intranasal testosterone, 5.5 mg per nostril, 2 sprays daily, provides a peak-to-trough variation of plus or minus 30% and is approved for patients preferring non-injectable routes, FDA 2020. For patients with chronic kidney disease stage 4, EGFR 1529 ml/min/1.73 square meter, a 25% dose reduction of injectable testosterone, e.g., 75 mg weekly, maintains therapeutic levels without excess accumulation, DIGO 2021. Overview and epidemiology. Male hypogonadism is defined as a clinical syndrome resulting from failure of the testes to produce physiological levels of testosterone and/or a normal number of spermatozoa, ICD-10E 29.1. Global prevalence estimates vary by assay methodology, but pooled data from 12 population-based studies, N equals 45,672 men, indicate a prevalence of 2.5% for total testosterone less than 300 ing/dl in men greater than or equal to 40 years, rising to 5% in men greater than or equal to 60 years, NANS 20152018. In North America, prevalence is higher, is almost equal to 3.2%, compared with Europe, is almost equal to 2.1%, and Asia, is almost equal to 1.8%. Age-related decline averages 1% per year after age 30, with a steeper slope, is almost equal to 1.5% per year after age 55. Racial disparities are evident. African American men have a 1.4-fold higher odds of low testosterone compared with Caucasian men, adjusted or equals 1.38, 95% CI 1.121.70. Economic analyses from the United States estimate an annual direct medical cost of $2.5 billion attributable to hypogonadism-related comorbidities, e.g., osteoporosis, type 2 diabetes, cardiovascular disease. Indirect costs, primarily lost workdays, add an estimated $1.1 billion per year. Pathophysiology. Testosterone biosynthesis occurs in Leydig cells via the steroidogenic acute regulatory (STAR) protein-mediated transport of cholesterol into mitochondria, followed by conversion through 17-beta-hydroxysteroid dehydrogenase, 17-beta-HSD, to testosterone. Primary hypogonadism stems from intrinsic Leydig cell failure, often due to genetic mutations, e.g., NR5A1, LHCGR, or acquired insults, e.g., mumps or orchitis, chemotherapy. Secondary hypogonadism results from hypothalamic or pituitary dysfunction, leading to reduced gonadotropin-releasing hormone, GnRH, pulsatility and consequently low luteinizing hormone, LH, and follicle-stimulating hormone, FSH. The hypothalamic pituitary-testicular axis is regulated by a negative feedback loop. Circulating testosterone suppresses GnRH, LH, and FSH via androgen receptors, AR, in the hypothalamus and pituitary. In primary hypogonadism, LH and FSH are elevated, mean LH equals 12.4 IU/L, FSH equals 15.2 IU/L, whereas in secondary forms they are inappropriately low, LH 4 IU/L, FSH 5 IU/L. Clinical presentation. The classic symptom complex, often termed androgen deficiency syndrome, includes decreased libido, reported by 78% of patients, erectile dysfunction, ED, 68%, reduced spontaneous erections, 55%, fatigue, 62%, loss of body hair, 44%, and decreased muscle strength, 41%. In a multicenter cohort of 3,214 men with confirmed low testosterone, the prevalence of each symptom was libido 78%, ED 68%, fatigue 62%, mood changes, depression or irritability 45%, and hot flashes 12%. Atypical presentations are more common in older adults, greater than 65 years, and in men with type 2 diabetes mellitus, T2DM. In diabetic men, the prevalence of ED rises to 84% and is often the sole presenting complaint. In immunocompromised patients, e.g., HIV-positive, low testosterone may manifest as profound sarcopenia, loss of greater than 10% lean mass, without overt sexual symptoms. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown. 1. Initial laboratory assessment, obtain a morning, 08:0010:00, total testosterone measurement using a liquid chromatography tandem mass spectrometry, LCMS/MS ESA, the gold standard with Interassay CV less than 5%. A value less than 300 Ing/dl, 10.4 nmol/L, warrants repeat testing on a separate day. Free testosterone can be calculated using SHBG and albumin levels. A free testosterone 9 pg/ml, 0.31 mol/L, is diagnostic in the presence of symptoms. References. 1. De Silva NL et al. Male hypogonadism, pathogenesis, diagnosis, and management. The Lancet. Diabetes and Endocrinology. 2024, 12, 10761-774. PMID 391599641, https://pubmed.ncbi.nlm.nih.gov/391599641. doi 10.1016/s2213-8587, 24, 00199-2. 2. Linkoff AM et al. Cardiovascular Safety of Testosterone Replacement Therapy. The New England Journal of Medicine. 2023, 389, 2107-117. PMID, 37326322, https://pubmed.ncbi.nlm.nih.gov/373263222. DOI 10.1056/NEJMOA 22150025. 3. Bandera et al. Male Osteoporosis. Archives of Endocrinology and Metabolism. 2022, 66, 5739-747. PMID 363827763, https://pubmed.ncbi.nlm.nih.gov/363827763. doi 10.209455/2359-3997000000563. 4. Heidelbaugh J.J. et al. Testosterone Replacement Therapy for Male Hypogonadism. American Family Physician. 2024, 109, 6543-549. PMID 389055552, https://pubmed.ncbi.nlm.nih.gov/389055552. 5. Jayasena CN et al. Society for Endocrinology Guidelines for Testosterone Replacement Therapy in Male Hypogonadism. Clinical Endocrinology. 2022, 96, 200-219. PMID 348117885, https://pubmed.ncbi.nlm.nih.gov/348117885. DOI 10.1111/CEN14633. 6. Wang C et al. Testosterone Replacement Therapy in Hypogonadal Men. Endocrinology and Metabolism Clinics of North America. 2022, 51, 177-98. PMID 3521672, https://pubmed.ncbi.nlm.nih.gov/352167222. DOI 10.1016/J.ECL.2021.11.005. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.